And thank you very much. The ABISS trial is a trial that is really specific in the field of DCBs for AV access. You know, when you look at all these studies regarding DCBs in AV access, you have to ask all these questions. Are they a physician or industry design? And you will see that the endpoints are not really the same. Who founded the study and how? Do we have a mix of fistulas and grafts? Right now, we generally separate these devices and procedures. Is this stenosis mixed with restenosis? Do we have duplex ultrasound prior to intervention? How is treated the control group? Is this really the same therapy without the paclitaxel? Our indication for reintervention well defined. And you can see that if you look in the details, the trials about the drug-coated balloon, the indication for reinterventions are not always very systematically decided. The ABISS is a prospective randomized multi-center trial. It's kind of double-blinded. You will see how. It's physician-designed trial that we designed somewhere around 10 years ago now. The primary outcome is a primary patency at 6 months, which is a combined composite outcome of reintervention and back to the initial AV fistula flow. Here are the secondary outcomes that are quite usual. The inclusion and exclusion criteria are also the same as most AV access study regarding DCBs, but in this study we always ask preoperative fistula flow using duplex ultrasound, and we have it during the follow-up at different time points, 3, 6, and 12 months. So the patient is selected, consent, and randomized, and he has standard angioplasty, and during the same procedures, and he has either the drug-coated balloon, which is a Lutonix balloon that has been provided by BD free of charge, and alternatively, he can have a placebo balloon, which is the ClearPack Omega balloon, which I didn't know, and probably you don't know either, which is in fact the same balloon as the Lutonix, but without the paclitaxel. It's really the same platform, and it was also provided by BARD. So, there is a blinding in this study regarding the indication for intervention. And once again, it's not always the case in all study. So there is 2 investigators in each center. One is the operator that does the intervention and that knows if he inserts a DCB or an uncoated balloon. But then the patient is followed by another investigator who is blinded to the treatment group and who will decide for later interventions. The indications were defined according to known criteria, so I will not go into the detail here. And now the enrollment and the follow-up is completed in this study. It was a 1-year follow-up. Unfortunately, I am not allowed to provide you the real results at that point because we still need some adjudication of the data. We still need to validate also some of the indication with an independent committee, but I can give you some basic data here. So you can see that as for most randomized trial, the enrollment is not always the same, and we have 3 main centers driving the inclusion here. You can also see that the randomization perfectly worked with a very well comparable group regarding the comorbidities, age, and gender. Also, you can see that the groups are comparable regarding the fistula flow and the lesion, but interestingly, in this trial, we have less restenosis than in other trials. We have a majority of de novo lesions. When you look at the Lutonix AV or the Impact AV trial, you have more restenosis rates. Most fistulas were on the cephalic vein, and most stenosis were juxtaanastomotic. There are also some variability regarding the treatment according to the centers and the operator, intraoperative heparin, also the use of the preparation balloon, which is not always high-pressure balloon in this study. It was the balloon that the investigator wanted to use to have perfect preparation. And you can also see that most of the time the patients were treated according to the IFUs, but even in expert centers and with protocols, sometimes the patient have short inflation time, a low inflation pressure, which is not really recommended. Here is a flow chart of the study, and I apologize for the slide, which may be difficult to read. And you can see that in this study, but as in all studies, there are concurrent events in our patients. Some of them stop dialysis, some of them die, some of them are transplanted. The death risk was not different between the two groups, but it's at 1 year. And the adverse event rate is also not different between the groups. The final result will be presented for the first time at the PVI in Paris in November, and I thank you very much for your attention. I thank also the investigator. Thank you.